here now in one of the evening of Guwahati. Really, it is a pleasurable task to describe about the various aspects of the recent advances in case of tuberculosis. So, in tuberculosis, in my talk that I want to present this evening, first let me have a just glance in my watch. So it is already 9:40. So I am supposed to complete this talk within 20 minutes. So these are the salient features that I will have to talk. The recent advancements regarding the treatment, diagnostics, and preventive aspects. So elimination, it is the goal ultimately to eliminate the tuberculosis, the disease by 2050. So tuberculosis. Whether it will not be possible in our lifetime, in our generation's lifetime, but it may be possible to the young sitting in the back of the audience. So there are various drugs. So we have come to know about the drugs that are used now traditionally, commonly used as a part of the DOX therapy. The traditional DOX therapy, category 1 and 2, earlier there was the category 2, 3, and now, of course, the category 4 or DOS plus has also come into existence. It has been extensively used, but the last amongst these drugs where the category 1 and 2 are used, that is your rifampicin. After the rifampicin, the derivatives of rifampicin have come out. It has not been, these had not been used, of course, so extensively, like for example, what I want to say that about that rifabutin and rifampicin. So, these two new drugs that you have seen, that are bedaquiline and delaminate. So these are the two drugs. This is the combination or chemical structure of these two drugs. These of course have been used. So let us first deal about these drugs. So it is said to be a new drug. It is just, you can say, the new drug, new one in the old bottle. So it is prescribed in for the use in case of your MDR tuberculosis in adults by the none other than the topmost authority in the United States, that is the FDA, in December 2012. So these are very recent development. So it is available in this particular 100 milligram tablets, and it is marketed under this particular name, that is the Savior. So the other drug, that is your bedaquiline. It decreases this energy production in the mycobacterium tuberculosis by inhibiting the ATP3 synthesis. So these are the various mechanisms. So it has got both its pros and cons, like most of the drugs. So there are, of course, regarding the discussion on the cons, the latter factor, it should be used only when an effective treatment regimen cannot otherwise be provided. That means it should be used in as a second line of therapy. Can cause, like other drugs, various other drugs. For example, in case of amitin, which we used long time back, about 3 decades back. So it has some obvious side effects in case of your particular in case of your heart. So you have to see the ECG that has to be done routinely in addition to the liver function test. So dosage regimen is this one that you have seen. The first 2 weeks it is for 400 milligram daily, and then this is for that means this drug, the total duration of with the help of this particular drug, that is your bedaquiline, the total duration of the treatment is not decreased. It remains the same, like your category 1. In category 2, of course, it is longer period. It is of longer period. So come to the other drug. So it is nitronidazole derivative. So it inhibits the mycolytic acid synthesis in the bacterial cell wall. So it has been used since November 2013. So this one is also a very new drug. So phase 2 and 3 clinical trials in US is going on. So it is recommended uses for this one that you have seen it here, the 100 milligram twice daily or 24 weeks. These are all 6 months. Again, it is for 6 months. So apart from these two drugs, these two products have already been in use. Some other drugs are on the experimental stage. So these are the newer drugs that you have seen. So Sudezolid, SQ109, PA824. So these three drugs. So let us have a bird's eye view. Bird's eye view on this drug. This is linezolid and this Sudezolid. So this is currently undergoing phase 2 clinical trial. So it has a long time yet to come. So it acts by inhibiting the bacterial protein synthesis. So if we compare with which is parent drug, the older one, so better antibacterial activity than compared to the linezolic acid in both this in case of your mouse model. So better time dependent killing of the bacteria, improved safety profile compared to this one. So continuing this thing, these are earlier bactericidal. Unlike some other drugs which are bactericidal, this is mainly a bactericidal drug. It has potential to shorten the treatment of duration, which is a major problem for the reason that non-compliance to the drugs is the reason which usually leads to the problem of MDR, which will come to immediately within a few minutes. So coming to this, again to this drug, it does not react with these enzymes which are usually liberated by the liver. It is not likely to react with the ART. So we can use it in that particular deadly duo infection. That is your HIV tuberculosis. So that is why it is definitely given a better chance. So the other drug, that is your SQ109. So this one is currently undergoing this phase 3 clinical trials in case of your MDR tuberculosis. So regarding this, the chairperson has already talked about. It is a mass graded problem. This is your MDR. So it is active against the drug susceptible as well as the multi-drug resistant strains of this particular tuberculosis. So it has got synergistic action with these particular traditional drugs. That is your INS rifampicin. So it has got some added advantage about these particular drugs. So next drug in the horizon is this one, PA824. So pretomanide. So this is what is drug? This from biochemical point of view, this is just a bicyclic nitro-imidazole derivative which is developed by this AB alliance. So this is a potent bactericidal and it has got also a sterilizing action. So this has undergone phase 2B and as well as the phase 3 trial. So this one, the P824, this has got 12 mechanism of action. It inhibits the cell wall inhibition and acts as a NO donor. So it has the main the dosage is usually 100 to 200 milligram daily. It has got synergistic action with this moxifloxacin as well as pyrazinamide. So now come to our very own India, Mera Bharat Mahan. So if we consider the situation here in India, so we will see that there is a new drug in the horizon here in our very own country, that is a Rizoride. It's a combination drug, of course, fixed drug combination. So this particular drug is the outcome that you have seen in the slide. There is nothing much to say. That CSIR in Jammu, there are 7 CSIR labs. One of these is in Jammu. So they have developed this with collaboration with the Cadillac Pharmaceutical. So it has got this rifampicin that Professor Jugesh Sharma, he has already talked about its pros and cons. So it has got this particular problems in the liver, and it has also got low and variable bioavailability, and it has got multiple adverse side drug reaction that Professor Sharma has already told that about 1/4 of the patients may develop this particular the hepatic side effect. So if we compare this one, Rizoride, with this one, so you will see that this particular problem, there are various advantages of this particular new drug. That has come into the market. Of course, it is available. So in case of tuberculosis, what I have seen from last few years of practice, basically I am a physician, a medical teacher, mainly dealing with the tuberculosis patients. What I have seen in Upper Assam, that this particular GIT side effects are more due to this particular, in addition to this particular risk of hepatitis. So these are much reduced. So this has got its own place. So these advantages are like this. It minimizes the drug-induced hepatitis, and also in addition to whatever it has been mentioned here, whatever you have seen in this particular piece of slide, what I want to say, what I want to add, that it decreases the required amount of dose because of the action of the piperine. So this particular drug what happens if we consider the situation here in India? Most of the patients are due to undernourishment and malnutrition. Usually, they cannot tolerate. They cannot tolerate this particular rifampicin. So, this particular drug, if we use, it has got some kind of effect. Of course, I will not say that this is a wonder drug or it is a magic drug. It has miles and miles to go in terms of the great literature. So it has still it has got its own plus points, and it has got, of course, drawbacks. So it has place in therapy. If you take a neutral view, it is ideal switchover therapy. It can be used for those patients who have got intolerable side effects in the GIT or in the liver, in a conventional, the 450 milligram dose of rifampicin. That means it can be given a trial. It can be used. It can be used. It can be used. Definitely, that is what I want to say. So, if you come to the regimens, usually it has been the main drawback that I have mentioned, that earlier it was for a longer time, that 6 to 24 months, it has been reduced, and the vision is to reduce it up to only till 10 days. So, newer regimens that have been in the horizon, the moxifloxacin, that has been tried as an anti-tuberculosis drug. It is currently used for the reasons that it is an alternative to INS and ethambutol in the treatment of drug-sensitive tuberculosis, and it shortens the duration. So, 500 names are also there in this particular subject of this particular tuberculosis. It is not that this is a non-glamorous infectious disease. So, Remox trial, it has been already been conducted. So, there are various sites, and this study duration, it was conducted from 2008 to 2014, Remox TB trial. So, this particular TB trial, the drugs that have been used, and you have seen that it can be completed. The course of the anti-tuberculosis therapy can be completed within a short period of 4 months. So, this moxifloxacin, these are studies actually that are ongoing. So, this what you have seen, that in case of your drug-sensitive tuberculosis, this is what you have seen, that these studies have undergone that they phase 2 trials. So these are the other studies that where the fluoroquinolone have been used. So the novel combinations that have been used, betaquinolone and moxifloxacin, PA824 and PZ8. So these are actually, this entire concept of this MDR tuberculosis is due. In addition to that, XDR tuberculosis, DDR, XSDR. I think most of this, the audience, learned audience, they are at a loss to know what are these actually. So let us, before going into that particular topic, let us have a look into this particular stand trial. That is shortening the treatments by advancing the novel drugs. So this first trial, this is the first trial to test a common regimen for drug-sensitive as well as drug-resistant tuberculosis. So this is another trial. So that has been underway. So this is 24 months conventional trial is tried against this investigational trial for 6 months. So another trial. This is that have been used with these newer drugs that I have mentioned already at the initial part of today's presentation. So, advancement. A few words about the diagnostics. So, regarding the diagnostics, these due to the advancements in the science, I would like to say that the period of the diagnosis have been shortened. All of us know in this learned and esteemed veterinary that the mycobacterium is a slow growing bacteria. It takes longer time than the other bacteria to grow, and that is the main disadvantage of the diagnosis. So in case of these advanced technologies that I have mentioned, this diagnosis period have been shortened much sorted, and I am proud to say, I would like to say that these are now available here in India, even our own state also, these are available, even in the government sector also, these are available. So this particular test have been used rampantly. So, Gene Expert, for this one, I would like to say that it has been used under the aegis of RNTCB. It is done free of cost. So, these have been used for a long time here in Guwahati Medical College and also in one PHC in Kamrup Rural District. So far, if I am correct, it is used in, I think, in Hajo. Yes. So, apart from this, I am glad to inform you that new machines have been procured by the government of India, and some of these are expected to come here to the state of Assam also. So the whole state of Assam will be covered with this free diagnostic procedure. And main advantage of this particular test is that it can be done on the spot as a, I mean to say, the OPD procedure. So it has got its own limitations, of course. So it can be done within 2 hours. So just now I have said that as an OPD procedure, it can be done. So if it is associated, these are the particularly useful situations. So these are the things. So MDR plus, this is the treatment that has got advantages. So regarding this particular diagnostic procedure, that I will say IGRAS, that we have to think or take into task against the backdrop of the particularly older test, that is your tuberculin or Mantu test. So it is a newer concept. This interferon gamma release assay test, it is a newer concept, and there are some reagents that have been used in this particular test. So quantiferon test. Again, this test, it has cannot differ. Nowadays, it is completely banned by the government of India circular that was from 2012. So why these were banned, or why these have to be forced to be eliminated? So I have mentioned the reasons, so you can see it. So there are various tests. So first it was the WHO, then it was the RNTCB who discouraged this particular thing. So it does more harm than good. So the take-home message is that never use serological test for the diagnosis of this particular dreaded disease, tuberculosis. So these are the newer tests that have been on horizon. It have been still in the experimental stage. So these are the latest and recent development, that breath analyzer screening test, and the second test that is usually takes the sample of the urine. So recent advances in the vaccination of this particular this thing, your tuberculosis. So this BCG replacement vaccine and boosters to the BCG vaccine have also been used. So regarding this XDR, the first, it was highlighted in an article that was published in the BMJ. That was in September 2006. So the whole problem of this particular BMJ, and later on the WHO report in 2008. So it was mentioned that it has come at a higher rate than ever. So this is the report. This is the summary of the WHO report where it was mentioned. So this is actually the definition. It has been modified and updated. The definition of this thing, it has been updated. This is the what it is. Apart from this too, there is XXDR, which is also known as TDR. That is a total drug resistance. So there is the ultimate eventuality that you know there is particle discharge only. So these are the types of resistance. So coming to this problem of resistance, so extent of the problem, so of the in case of SDR. So coming to the drug therapy, if you go, just I want to skip this slide. Just I will tell you, just one. Yes. So if you see this slide, the various groups of drugs that are presently used. That use first line drug, injectable drugs, fluoroquinolone, and also the second line group of drugs. So these are the drugs that are presently being used just to repress your memory. And in addition to this drug, whatever I have mentioned in the first few slides, those were the drugs that are on the horizon, and moreover there are some drugs that are on the experimental stage. So these are the drugs. Apart from this, so let us see another slide. I think I can conclude. Yes, this one.